Thank you so much for being here today. This is a discussion on advanced care planning, and my name is Amanda Tavelda, and I will be your host and moderator today for our small group. And before we do jump into the nitty-gritty bits of the advanced care planning, I'd like to do a land acknowledgement. We would like to acknowledge that the land which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of the Chippewas of Beausoleil, Ramit, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous First Nations across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us came here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And as you know, this is part of the Palliative Care Echo Project. The Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare providers like yourselves. And we would like to thank Health Canada for their financial contributions to this project. Thank you, Health Canada. And now I'd like to introduce our presenters for today. I have already introduced myself. My name is Amanda Tavelda. I'm Communications, Fundraising, and Community Relations Specialist with Hospice Aurelia, which is part of the network. And our presenters are Laura Bates and Linda Meeks, who are both palliative pain and symptom management consultants with the North Simcoe Muskoka Hospice Palliative Care Network. And they hold the mentorship and education portfolios. Ladies, the floor is all yours.
Thank you, Amanda.
Thank you, Amanda. Thanks, Amanda. Just a quick reminder, if you have your smart device next to you, to bring up our survey to give us your feedback when we are finished our presentation.
So, hi, Laura. Thanks for joining me today. And just to let everyone know that April is Advanced Care Planning Month. So this is why Laura and I chose this topic for ECHO presentation this month. And just to note that our presentation today will focus on advanced care planning, specifically in Ontario. And each Canadian province and territory has specific and individual laws and regulations regarding advanced care planning and substitute decision making. So please consult the province or territory in which you practice and or live for applicable laws and regulations.
Thanks for that reminder, Linda.
So the learning objectives that we have set out for today, by the end of the session, participants will be able to understand and describe the process of advanced care planning in Ontario. We're hoping that you understand what is required for informed consent, that you'll be able to discuss and apply the components of person-centered decision-making, and understand and begin to apply a variety of conversation tools to assist with advanced care planning conversations. So just imagine you have been in a serious car accident. You are in critical condition with head and neck injuries. The medical team says that you require a blood transfusion, but it's against your religion. Who will speak for you to inform the medical team of this? Amelia was working out in the gym when she complained of a severe headache, loss of speech, and nausea. She was taken to the hospital where she was diagnosed with a subarachnoid hemorrhage and required surgery. Who will speak for her to consent to surgery? Pierre and his husband, Scott, are planning a hiking trip to Kathmandu, and Pierre wants to get travel insurance to prepare in case something goes wrong. Who will speak for him if he is injured and requires medical treatment? Have you ever thought about who will speak for you if you are injured and unable to make decisions for yourself? So these are some of the common desires when we think about death. Most of us think that we would like to live forever, that we would be fully able to participate in our life and then die suddenly in my sleep. We would like to die at home and to die a pain-free death. And all of us would like to die with our dignity intact. And these are some assumptions about end-of-life care. We assume that friends and family can and will take care of us, that friends and family will all agree and make caring decisions throughout our illness trajectory, and that care will be available when and where we need it and to the fullest extent. Laura? So here's the truth. Of the top 10 causes of death in 2021, taken from Statistics Canada, that was published in 2023, of the top 10 causes of death, 7 were due to chronic disease and cancer. 3 were due to infectious diseases and unintentional accidents. And death due to chronic illness are not instantaneous deaths, meaning that the majority of us will have some type of period of illness and decline between diagnosis and death. Unintentional accidents include fatal overdoses, as they are actually classified as accidental poisoning, and falls due to routine or sporting activities. Falls represent more than 2/3 of all accidental deaths of Canadians over the age of 65. And drug overdoses account for 95% of the deaths attributed to accidental poisoning. So you can see here the list of 10 things in order. So number 1, malignant neoplasms. 2, diseases of the heart. 3, unintentional accidents. 4, COVID-19. 5 is cerebrovascular diseases. 6, chronic lower respiratory diseases. 7, diabetes. 8, Alzheimer's disease, and 9, chronic liver disease and cirrhosis, and 10, influenza and pneumonia. So why is advanced care planning important? Advanced care planning is important as it makes your future wishes regarding your health and personal care known and followed. Your family and friends will have less stress and anxiety when making decisions about your care. You will have a better quality of life and death, and you and your family and friends will be more satisfied with the care that you receive. Advanced care planning has evidence-based benefits for the patient, for their friends and family, healthcare providers, and the healthcare system as a whole. Advanced care planning is the gift you have given to your substitute decision maker based on what you would want and value in life. These wants and values will guide them to make healthcare decisions to treat or withhold treatment when you are unable to understand or appreciate the consequences of a decision, such as accepting or refusing care. Advanced care planning is listed in the Healthcare Consent Act. In Ontario, there is no such thing as advanced directives or a living will. Sometimes you hear people say these terms. These are American terms and actually not legal in Canada. These terms are mistaken for consent and future treatments, whereby advanced care planning is a discussion with your substitute decision maker about getting to know what you value and would want should you be unable to speak for yourself. So in Ontario, the law requires all healthcare providers to get informed consent or refusal of consent before providing any treatment or care. Normally, you are informed of your illness and treatments, and you're involved in the treatment plan. In a life-saving emergency, you may not be able to give consent, so who would then give consent for you? That would be your substitute decision maker. So what makes consent informed? The consent must be related to the proposed treatment. It is given voluntarily, not obtained through misrepresentation or fraud. The individual giving consent must have the capacity to do so. The information provided must include the proposed treatment and its expected benefits and risks, the alternative treatment or treatments and expected benefits and risks as applicable, and the expected benefits and risk of refusing the proposed treatment. Capacity to give consent means that one is able to understand the nature and anticipated effect of proposed medical treatments and the alternative treatments, and therefore appreciate any consequences there may be from refusing treatment. When a patient does not have the capacity to make a medical decision, it falls to their substitute decision maker to make the decision for them. As mentioned previously, decision making is based on values, beliefs, and wishes. How will the substitute decision maker know what to decide? Will they make the decision based on the known or guess values, beliefs, and wishes of the patient? So, types of decisions in healthcare. There may be a decision having to be made about long-term care placement, consent or refusal of tests, procedures, or surgery, the initiation or withdrawal of life-prolonging measures, and who will provide medical care, admission, discharge from medical facilities, and goals of care discussions. Statements that are not helpful when you're planning to make decisions in healthcare and working with your substitute decision maker are no heroics or no machines. Does that mean ever? Or what if there is no chance of recovery? What if there is a 90% chance of recovery? What about the term no tubes? What if the circumstances were short term and reversible? Would a tube be acceptable then? Or the term do everything? What does that actually mean? What is it that you want to have achieved? And how will the substitute decision maker know when everything has been done? So there are two parts to decision making. There is the person and the treatment. So obviously the person has values and goals about their treatment, what's important to them and why it's important. And they must have information about the treatment with evidence about diseases and about the treatment. And they put these two items of information together to be two parts of the equation, and both are needed to be effective. Once you know who your SDM is, how does that tie into advanced care planning? Advanced care planning conversations are not the same as goals of care conversations or healthcare consent to medical treatment. It differs because it is about values and beliefs to decide on future care. Goals of care is a current care discussion. What are your personal and clinical goals based on in your current condition? Do you want to walk again? Do you want to be pain-free? Do you want to drive? And those types of decisions.
So let's talk about the steps of advanced care planning and what it is in the context of Ontario. So there's 5 steps when we talk about advanced care planning in Ontario. The first is to identify and confirm your substitute decision maker. Then you should learn about your current health conditions and any possible future treatments associated with them. Then you need to think about what's important to you, those values, beliefs, and wishes that Linda spoke about that guide the decisions you're making in regards to your health. Step 4 is to talk about these things with your substitute decision maker, your family, your friends, your healthcare providers. It's really important, if you are able to record some of this information so that it's easy for those people who need to know it in the future to access it. And then the final step is to include your substitute decision maker in ongoing conversations as your health changes, or if your values, wishes, and goals change, so that they are kept up to date with the things that you may or may not want in the future. So let's go through this step by step. So the first step is, who is your automatic substitute decision maker based on the hierarchy? So the Government of Ontario has put into law that everyone has an automatic substitute decision maker. So as I was saying, the Government of Ontario has enacted into law the ability for everyone to have a substitute decision maker, so that in the horrible instance of a catastrophic event in your health or an accident, you automatically have somebody who is legally nominated to make healthcare decisions for you if you're not able to speak for yourself. But we need to figure out whether that automatic person, A, has the ability to make these difficult healthcare decisions potentially in a time of crisis for us, And B, would they be able to make decisions based on your values, wishes, and beliefs, as opposed to their own or other outside influences? So let's look at the hierarchy. So if you have a court-appointed guardian, an attorney for personal care, or a representative appointed by the Consent and Capacity Board, they are automatically your legally appointed substitute decision maker. So these are people who have been specifically chosen to speak for you, whether by yourself or by another legal entity. If you have none of the three in yellow, those legally appointed SDMs, then comes into play the green section. And these are your automatic family member substitute decision makers. So these are the people from top to bottom who would be asked to make a decision for you if you're unable to speak for yourself, whether it's at end of life from a chronic illness or in the instance of an accident or a catastrophic health event. So first they would look to your spouse or legal partner. So that would be in Ontario, somebody that you're in a legal common law relationship with or a marriage relationship with. Then if you don't have that person or that person is unwilling or unable to do it, they would go to your parents and or your children. Then they would move to a parent with right of access only. So that would be in the case of a minor child who has a non-custodial parent. Then it would go to siblings. Then it would go to literally any other relative by blood or marriage that they can track down. If they get through all of those green levels and there is nobody, or the people who are there are unwilling or unable to make decisions for you, then the substitute decision maker of last resort would be somebody from the public guardian and trustee. So a complete stranger who gets nominated and adds you to their case files and would get phone calls to make decisions on your behalf. And they are somebody who has never met you and has no idea what your values, beliefs, and wishes are in regards to your life or your health. So we'll talk about this a little bit later, but it is noted that if you have multiple people on one of the green levels, then all of those people would have equal decision-making capabilities and would have to come to a consensus in order to make a decision for your health. So if you are an adult who has adult children and adult parents who are living and everybody is capable of making a decision for you and willing to make decisions, then they would all have to be brought into the decision-making process and would have to come to a consensus on the decision. There are some ways around when there's multiple people, but we'll talk about that a little bit later when we get into some case studies. But there are some ways to work around lack of consensus or lack of willingness from somebody on those levels if there's multiple people. So I want you all, even if you're not in Ontario, to just think if this was you and we were looking at the green areas because you didn't have a legally appointed SDM, who would be your automatic SDM? And would you be okay with that person making decisions? Just something to ponder as you listen to our presentation. So in order to be a substitute decision maker, you have to be willing and able to make those on your behalf. They should be willing to honor your wishes, even if it's not what they would choose for themselves in that situation. They need to be mentally capable of speaking for you, even under a stressful situation. Legally, they have to be at least 16 years of age, and they have to be available to make the decisions when they're required. So they need to be able to be in contact by phone or whatever it happens to be according to your facility's policies. So next step is learning. And this is important because we need to think about what kinds of decisions we might need to make in regards to our health and the information we're going to need for those decisions. So you need to know, and your substitute decision maker should have some of this information also, you need to know about your current medical diagnoses. If you've been diagnosed with something, talk to your doctor, see if they've got booklets if you need more information, see if they will, book a visit with you to chat and answer some questions. There are some reputable websites, but I would caution against just doing a generic Google search on your new diagnosis because you will often either see the worst case scenario or get information that may not be completely applicable to you. So please just remember Dr. Google is not always a good source of information. There's lots of disease societies and communities out there. So for example, the ALS Society is a wealth of knowledge. The Alzheimer's Society's wealth of knowledge on all parts of these specific diseases, what to expect, things you should be asking your healthcare team, how to care for somebody with these diseases. It's all out there. And if you have trouble finding it, speak to your care providers. They will be able to link you to those sorts of resources. You need to think about projected illness trajectories based on your health. So this is not just those illness trajectories we see that map out end of life decline, but what sorts of things could happen? So if you're diagnosed with diabetes, you should know that you potentially might have kidney issues in the future. You might potentially have circulation issues in your extremities. You might have specific complications depending on the other diagnoses you have. And you need to think about whether some of these complications or expected outcomes are reversible or not, and if they are reversible, how easily treated they are. These are all questions for your healthcare team. You also should be thinking about the likelihood of these adverse events or complications based on your current medical status. You know, if your blood, for example, diabetes, because it's an easy one that everybody has a bit of knowledge about. If your blood sugars are very well controlled, your likelihood of complications or adverse issues due to your diabetes goes down. You know, you're not as likely to have kidney issues. You're not as likely to have circulation issues. You're not as likely to have nerve damage. And then thinking also about your possible medical procedures and future potential medical issues. So things like dialysis. If your kidneys were failing due to your disease, what do you need to know about what dialysis entails? You might just need a general basic knowledge level now until things change in the future. But being aware of the potential is important. And again, other things like potential surgeries to help or to treat, chemotherapy or radiation, things like artificial hydration or nutrition, potential medications, trials, all that sort of thing. All good things that as patients we should be asking about, and as healthcare practitioners, we should be providing the information to our patients when they ask. You should also think about these types of terms. What does an allow natural death actually mean? What does CPR entail? What is end-of-life care? What does frailty mean? What does hospice palliative care mean? What does life support or life-sustaining measures entail? It may change depending on the facility that the patient or client is in. It might mean something different if you're already admitted to hospital versus if you're at home in the community and calling 911. So these are all important things that need to be thought about. And if you don't know, doing the research and asking. So the next step is think. Think about what's important to you. Think about what you value in life. What do you worry about most when you think about your future health? And if you were dying, what are your favorite routines and habits? What makes your life meaningful now? What would make your life meaningful still in the future if you had a chronic illness or a terminal diagnosis? What life circumstances would you find the most unbearable? Would having somebody assist you with personal ADLs be unbearable? Would life be unbearable if you couldn't attend your favorite sports team's games? Would life be okay, even if you were in poor health, if you were surrounded by your loved ones at home? That's the kinds of things to think about. Are there favorite ceremonies or special events? What gives you strength when things are rough, and what is important for others to know about you if you're ill? These are good questions as healthcare practitioners to ask your patients when you're exploring their values, beliefs, and wishes, and those goals of care conversation. The next step is to talk. So you're going to talk with the person who's going to be making decisions for you if and when you're unable to do it yourself. And you're going to talk about it with your healthcare team, your current healthcare team, and make sure that anybody new that comes in is given this information also. So if you record it, making sure they get a copy of it. If you've got somebody that can help you speak to this, great. It might be simply saying, I'd like to have a conversation about this. I'm ready to have a conversation about this with you. So I love this cartoon because it shows a couple sitting on the couch, and the gentleman says to his spouse, honey, I would like to ask you a favor. And she says, what? He goes, I do not want to finish my life in a vegetative state dependent on machines. If that ever happens, just pull the plug. And the last picture, in case you're not able to see it clearly, is she gets up and unplugs the television set. So he was clear he wanted to not be dependent on a machine, but he was not clear on what kind of machine. So a little bit of humor. As we know, those of us in hospice palliative care and in healthcare in general tend to have a little bit of a dark sense of humor. So just a reminder, clear questions and clear information is needed. So the next step is include your healthcare team and include your substitute decision maker, especially in some of these conversations, whether it's taking them along to a doctor's appointment, whether it's letting your visiting nurse know that you've had a discussion with your family and here's what you've told them. Whatever that happens to be, make sure you're including everybody in these types of discussions who needs to know this information. And then our last step and thought is review the wishes regularly. And this isn't an official step, but this should be done on a regular basis. Whether it's, every few years because things have stayed the same and I just want to ensure that everybody knows nothing's changed, or maybe you've had a change in your health. Maybe you've changed your mind about a certain intervention. Make sure that you're reviewing it on your own. Have your wishes changed? Have your values changed? Have your desires changed? And if they have, reviewing it with the people who need to know these things. So let's talk a little bit more about advanced care planning, Linda.
Right. So remember, advanced care planning is a process. It's a process of reflecting and communicating values, beliefs, and goals of care. And this process can be several conversations over a long period of time. And it should allow time for the person to think, process, and consider options. And this process should allow time for the gathering and understanding of information. And Laura, you spoke about that, the gathering of information with your healthcare providers. And remember that it's a process of planning for a time when you cannot make treatment decisions. And consent for or refusal of treatment has to come from the individual in Ontario. So your substitute decision maker interprets your wishes to guide the decisions that are to be made. Advanced care planning is a process of discussing with family, friends, and healthcare professionals, obviously the information about your disease and also your values, wishes, and beliefs, as we've mentioned before. And it's a planning, determining, and appointing an actual substitute decision maker. And it's a process of sharing your wishes. So as we can see, it is a process. And as mentioned previously, it can change over time based on your condition, based on your age, based on how your values and beliefs may change. Advanced care planning is not a one conversation only that happens and occurs with your treatment options with a physician or other healthcare provider. Advanced care planning is not consent to treatment, and it is not strictly a refusal of medical treatments. And it is not a document form or checklist to be completed. It's a process of conversations. So how can healthcare providers encourage advanced care planning? Sometimes these are difficult conversations. People find it difficult to bring about these conversations, but it's very crucial in all instances, especially if you've been, admitted into hospital and there are some decisions to be made. right at that point in time. So you can utilize websites, handouts, booklets, videos to provide information to patients and their families or their caregivers as early in the illness trajectory as possible. So it's always fantastic to start these conversations early. As mentioned, it is a process. So you might have a conversation at your first visit to your family doctor, then go home and have a conversation with your family or your substitute decision maker, and it's a process. Utilize evidence-based conversation guides and tools that are backed by research to guide your discussions with patients. And we're going to give you some resources in the next few slides. Complete your own advanced care planning and self-reflect on whether you have biases or beliefs which may impact how you discuss this topic with your patients and their families and caregivers. So for example, people who may come from a different culture, a different background, we have to make sure that we're not reflecting our beliefs onto those families or the patient. And practice, practice, practice. So as they say, practice makes perfect. And the more often you bring about these conversations, the easier it gets and the better you will be at helping people do advanced care planning. Okay. And one of the conversation frameworks that we like to use is I wish, I worry, I wonder. So the words I wish aligns you with the patient's hopes. The words I worry allows for truth-telling while being sensitive. And I wonder is a way to make a recommendation and discuss things further. So I'm just going to give you an example. If you were sitting talking to a patient and their family about, an illness trajectory, you could say, I wish things were different, to open up the conversation. That's letting you know that you are recognizing that the patient has hopes. You would say, I worry that your condition is worsening. So this then is a way of truth-telling while being sensitive. And then in the conversation, you might say, I wonder if we should discuss what your future may look like. So then you're opening the door to have a conversation about recommendation and discussing things further. Okay. And you can also use the SPIKES protocol for breaking bad news. So obviously that the S stands for setting. What setting are you in? Are you in a busy emergency department? Are you in someone's home? Are you in, a room in the hospital? And sometimes privacy can be an issue. So obviously you want to recognize what type of setting that you're in. Perception of the condition and its seriousness. So does the patient, client, or family have a perception of their condition and how serious it is? Sometimes people do have a terminal illness and they don't actually have a perception of how serious their illness can be. So that may be up to you to deliver that information. So you're going to want that invitation from the patient to actually give more information. And then the K stands for knowledge and giving medical information and facts. And we mentioned that, those facts may be what treatment options are available, and always recognizing that you have to give the risks of the treatment that you're offering, or there may be a choice of no treatment and what is going to happen if there's no treatment. You can explore emotions and sympathize, and strategy and summary. So then basically that means that you and your patient and family will come up with a strategy and summarize how you're going to move forward with your recommendations, what they're choosing to do for their illness. So here's some tools for advanced care planning. And I believe you do get a link to the copy of the PowerPoint, but we can also post these as resources on our information regarding the ECHO presentation. So these are some fantastic websites. Canadian Virtual Hospice. And when you go on there, you would click on Tools for Practice for Professionals, and then Communication. And in there, there's a variety of videos and electronic material. Ariadne Labs, that they have a fantastic serious illness conversation guide for clinicians and a booklet that's entitled What Matters to Me. And this can be given to people with serious illness for patients, and they're both downloadable. And that I wish, I worry, I wonder phrase that we just spoke about comes actually from that conversation guide, as well as the spike protocol. Okay, next, and Advanced Care Planning Canada website, again, a variety of videos and electronic printed material for healthcare providers and for patients and their families. And the Ontario Palliative Care Network site, there's a palliative care toolkit for a variety of tools on having conversations. If you ever get a chance to actually take the serious illness conversation course, I highly recommend that. It's a fantastic course.
I would have to agree, Linda. I found it extremely valuable and extremely helpful. And sometimes you just need the steps laid out in front of you if you're not comfortable with these types of conversations, to help you initiate them and make sure that you're touching all the bases that you need to. And I find if you say up front to a patient or their family, you know, I've just got this conversation guide here to make sure we don't miss anything important, they're completely understanding that if you've got a piece of paper in front of you to help jog your memory of some things to ask or some things to say. Yeah, and a lot of these resources, if you don't have, you know, a peer that you can role play with, are videos that you can watch and sort of pick up tips and pick up lines that you can use to help you with these conversations if you are not as comfortable or familiar with them. I'm all for using guidelines until it becomes second nature, when you're not good at it and you're just getting started. So let's do some case studies to kind of practice what we've learned and practice some of these things. So our first case study is about Jasmine. And remember, these are the context of Ontario, so it might be a little bit different for where you practice or live. So Jasmine is a 55-year-old woman who married later in life and has no children. She's estranged from many of her siblings, and her parents are both deceased. Her wife has just moved out of the home because the couple is separating. And a little bit of backstory, they've been estranged for many months before this. Jasmine is very close to a group of coworkers that she's had for over 20 years. In the past, she's always said she would never want to be kept alive if she was very disabled or unable to care for herself. She has poorly controlled hypertension and type 2 diabetes that is also poorly controlled, even though she's on both oral medications and insulin. So she sustains a significant brain bleed and undergoes emergency surgery and is now in the care of the intensive care unit. Her doctors have called her wife, and her coworkers are at the bedside. And the doctor explains that if Jasmine does survive to leave the hospital, it is highly unlikely that she will be able to care for herself ever again. So think about, what if advanced care planning had been discussed early on and Jasmine had done all these things we talked about, what this would look like. And I'd love to hear some input from people, either just unmute yourself or throw it in the chat. Who would the doctors be talking to? What kinds of information would they need from her family? What would this look like if we had done good advanced care planning ahead of this catastrophic event? Any thoughts? Or maybe, what do you think it would look like if advanced care planning had never been discussed before this point in time? I think we've all had a situation where nobody knows anything about what needs to happen with a patient and their care people. Catherine says everything would be in place, and although she's separated from her partner, she would have said whether her partner can speak for her. Yep. Carol says she'd have her SDM of choice designated. That's right. So let's see what happens in each situation based on what we've learned. So if Jasmine and her doctor had discussed advanced care planning in the past, this is what could have happened. Because she has diabetes and blood pressure control issues, advanced care planning is introduced early in their discussions about her disease and its control. They've discussed her goals for medical care and who she wished to be her substitute decision maker if she was unable to make decisions for herself. They also discussed her desire to maintain her independence and not rely on others for care. At her doctor's recommendation, she documents these values and wants a coworker to be her substitute decision maker. Her coworker agrees and is aware of these wishes. Sounds like a great situation. And because of this and her poor prognosis, the decision is made with her substitute decision maker to provide a palliative approach to care, and she dies peacefully with her closest friends at her bedside a week later. So, what happens if none of this has been done ahead of this catastrophic event? So at the hospital, the medical team contacts her wife as she's the automatic substitute decision maker based on the hierarchy. Her wife is unaware of the conversations that have occurred about Jasmine's wishes and values and has no idea what Jasmine would want in this situation. She's clinging to the fact that the medical team has indicated there is still a small chance for survival and asks them to do everything possible to sustain her life. A feeding tube is placed, and once she is stable, she's transferred to long-term care as she's fully dependent on others for all of her care. Did this meet the values, wishes, beliefs, and goals of Jasmine for how her life should look? No, you're right, definitely not. So, in that case, the healthcare team did what was legally required. They went to the legal automatic substitute decision maker based on the hierarchy, but that person didn't know what Jasmine wanted. So they couldn't make a decision based on those wishes. They made a decision on a guess or on their own values and beliefs. So let's do another one. Doug and Karen. They're in their 50s, married, and they have 2 teenage daughters. One is 17 and one is 14. Doug and Karen are in a car accident when traveling together, and both are in hospital, unable to speak for their own decisions. And they've both named each other as power of attorney for personal care with no backup. So they are not only not able to speak for themselves, but they're not able to speak for each other as they have legally indicated. They both have parents who have come in from out of town, and the teenage daughters are at the bedside, and they're there to find out more about how they're doing. The medical team is unsure of who to ask because there's no backup power of attorney for personal care. And based on the hierarchy, parents and children over 16 years of age have equal decision-making capabilities and ability. So who is, well, I kind of gave that one away. Who is the automatic substitute decision maker based on that hierarchy for Karen and Doug? It's their parents and their children, but only the older one, that's right, the one who's over 16 years of age. So let's talk about what happens if there's multiple people. If there's multiple people, the way the law is written is all of those people must come to a consensus and make a group decision together. If they wish, they can nominate one person to speak and speak on their behalf and make decisions on their behalf under the assumption that the group is discussing things off to the side or at a different time, and then one person is coming back with the decision. So in this case for Karen, her automatic substitute decisions makers would be her 17-year-old daughter and both of her parents. And as a group, they could decide if one person is going to speak for the group or if they're all going to work together. And for Doug, it would be his parents and the daughter. If somebody wants to step back, they are more than able to. Nowhere in the law does it say that just because you are not automatically listed that you have to be willing to do it. So any of those people could step back and say, no, I'm not willing to make these decisions. And the parents might speak to the 17-year-old about whether she wants to make these kinds of decisions at only 17 years of age. It might not be appropriate for her to be making these kinds of decisions, or she might be super mature and insightful and able to handle that responsibility. And that would be up to everybody involved in the care of Karen and Doug to figure that out and make sure that she's supported either way. But think about what would happen if your automatic substitute decision maker is your 17-year-old child. Is that a responsibility that a 17-year-old should have to deal with or could deal with for most 17-year-olds? And if their substitute decision makers are automatically their respective parents, but their parents are frail or quite elderly or unsure, what might happen if the decision making is left to them? So again, things to start thinking about both for yourself and both for the context of the decision making that your patients and their families are making. If you have a patient who doesn't have, at least in Ontario, a legal power of attorney who's willing and able to do these things, do they understand the ramifications and potential impact of using their substitute decision maker that's on the automatic hierarchy? It might not be somebody who's capable or able to do this, or it might just be something that they don't want them to do. So then let's do it from the other side. Let's talk about as a healthcare practitioner. So Mrs. Cho has seen her primary healthcare practitioner, which is a nurse practitioner, on 3 different occasions in the last year for COPD exacerbations, which have been managed with oral corticosteroids and antibiotics, along with a change in her inhalers. Last week, she had an exacerbation that required a 3-day stay in hospital to manage her symptoms because her son was visiting and called 911 due to her shortness of breath. On all previous visits, the nurse practitioner has attempted to discuss advanced care planning with Mrs. Cho, but she's defensive and refuses to discuss anything related to her health becoming worse. And we've all had patients like that who either are unwilling or unable to have these conversations in a timely manner or when it would be good to think about ahead of time. So Mrs. Cho is expected for her follow-up visit after her hospitalization, and the receptionist has let you know that her son has informed that he is accompanying her since she now needs to use a wheelchair due to weakness and shortness of breath while ambulating. What kinds of tools would you use as her healthcare provider to approach this visit and a discussion about advanced care planning with her? What of the tools that we've talked about today could you use to support your conversation with them? Go ahead and pop it in the chat or just unmute yourself. Oh, I see a serious illness conversation tool. Yep, that would be a great one. The I Wish, I Worry, I Wonder framework. Somebody suggested SICG and the Wish, Worry, Wonder framework. Great. Is anybody willing to be brave and unmute and just give us a little tidbit of how you'd open this conversation using one of these tools or frameworks? Just as an example for somebody who maybe isn't sure how they'd actually phrase this. Maybe you've had a similar conversation with a patient or somebody that you care for. We've got a few minutes. I'd love to have some examples if anybody's brave.
I can certainly start. I do love this.
You, Nancy.
I think once I start, hopefully someone else will come along behind me, right? So we do see this all the time. It's not brand new to us in any way. And I usually start my conversations by asking what they know about the disease that they have. That's usually my opening line. And if there's family present, I think this is such a blessing that her son is coming along. He's going to be a wealth of information and really finding out what does he know about what's happening.
Yes. He may know nothing. She might have told him nothing about what's been going on.
That's exactly right. That's exactly right. So that's just my opening line. I'll let someone else take it from there.
Okay, so anybody else want to be brave? What would you do after you get a gauge on their level of information?
I would just give them time to explain all of that and see how what they think about things. There have been multiple hospitalizations, and now she is becoming more debilitated. And what does she herself see, and what does her son see? And give them time to explain that and to talk, to try to use, as much as we try to lead these conversations or want to, interject, we have to be silent and let them speak, give them time to explain how they're feeling about everything.
Excellent. Thank you, Catherine. It's really important to let them get all of that out before we try and either, correct misinformation or provide additional information. We need to make sure we let them get what they need out first. So anybody else, once you've got sort of that good understanding where everybody knows exactly what stage she's at right now, what would we do next?
I guess we could give more information as the practitioner about where they, as a physician or nurse practitioner, see the illness, that trajectory, how it's evolving, and explain that, and what maybe other treatments might be involved or not involved. There may not be any further treatments, but to just hold the status quo in that illness and find out how they feel about that. Like, what have they made any plans for, try to find out if they've made plans about this illness becoming worse, as it seems to have become worse at this moment.
Yep. And letting them guide the amount of information and the type of information that we're providing.
Absolutely. Yeah.
She may say, I need to know everything, give it to me all. Or she might just say, give me what I need to know to manage with my current status, and we'll deal with the next decline when it comes. Or I'm not ready to think about that far ahead. Let's just think about the next couple of months.
Right.
Yeah, that's good. That's good.
I don't know
and
if
again,
I would.
Sorry, go ahead.
I don't know if I would be brave enough to do this, but I know some clinicians would actually use the diagram of the trajectory of organ failure and try to make that personal with her condition, the recent frequent exacerbations, etc., and also using it to demonstrate how, after particularly this last exacerbation, she has not come back to her previous level of function.
That is so important, Carol. Thank you. Thank you for being brave and speaking up about that. It is something that I have personally used, not very often. Sometimes that visual aid is helpful, especially in organ failure and that trajectory, because every time people bounce back, even if it's not quite to the place they were before, they've always bounced back. And it becomes the expectation. We'll deal with the crisis, but the crisis won't be the last one. So important to speak about how eventually this is going to repeat itself over and over again, for sure. Any other thoughts about this conversation? Of course, this is the assumption that they're receptive to this conversation and willing to have this conversation at this time. Does anybody else have any ways they would approach it?
Just one other
yes,
thing.
Nancy. Go ahead, Catherine.
Just to throw a wrench in everything, she's arrived there with her son because she is now in a wheelchair, but she is still capable of making decisions like, are they going to ask for consent to allow him in there with the nurse practitioner and the physician to listen to all of these conversations they have? Like, I wonder if she's going to be open to that. So, because sometimes that happens too. And it's like, oh, I don't want to talk about this in front of my family. Like, I'm not.
So definitely you could approach it with, thank you for coming with your mother. I'm going to speak to her alone for a couple of minutes to let her know what I'd like to talk about, and then get her permission for you to be in the room too. And she might say up front, no, it's not a problem. Bring him in now. It doesn't matter what we're talking about. Or she might say, yes, I want to know what we're going to talk about first before I decide if he's going to be in the room or not. So again, also very important, because she is, she doesn't have advanced dementia. She doesn't have any other cognitive issues that would prevent her from being capable of making decisions right now. And so that's good to note.
Also, too, just looking at her name, we have to look at culture, and Mrs. Cho appears maybe to be Asian, and they don't want to talk about end of life things. That's taboo for them. So have to be really careful with some of this.
You have to be able to read the room and know your patients, and know, what kinds of topics you're able to bring up and how gently or how bluntly you need to be. So that's some good thoughts. So I hope that's got everybody's brains working about how to approach these types of conversations, and how easy some of these tools are to just guide each of your questions or each of your talking points. So you'll see that for each province and territory, when you get a copy of the resources, that the full link is here for each of the provinces on where to go to find information specific to the province and territory. So that's these two slides. From these links, you'll be able to figure out what the legal requirements are for each area and what the processes are for naming substitute decision makers and doing powers of attorney. So Amanda has also added in the chat the link to our website where some of this can be found also. So we hope you've enjoyed today's session. Just a reminder to please do the survey. We'll also send it out with the recording and PDF file. And just to be mindful of your time, thank you for coming. But if you have any outstanding questions, we're happy to stick around for a couple of minutes to try and answer them.
Thanks for coming, everybody, on Advanced Care Planning Month.
Thank you, Laura. Thank you, Linda. That was fantastic. Thank you so much. I do have a question.
Go for it.
So what do you do in the situation where that last case where Mrs. Cho, her son was there? And what if her son is not receptive and shuts down the conversation every time you bring it up? So you want to talk. Do you have a DNR? Well, he shuts it down, doesn't want to talk about it, and yet he never leaves. So you never have that opportunity to talk with your client, your patient, about what her wishes are.
It's a very difficult line to walk between needing to push a little bit because there are some pieces of information and decisions that might need to be done ahead of time, and respecting the cultural, spiritual, and personal values and beliefs of your clients and their families. I think maybe being able to speak to him separately might help. Maybe he shuts it down because he's of the belief that if his mother gets all this negative information, she'll just give up and not be willing to do anything, and she'll just die faster. Maybe that's his belief. Maybe that's a cultural thing. Maybe that's his personal belief. Maybe he doesn't understand the need for planning for the worst, but hoping for the best in terms of just the legality of things. Maybe it's none of those. And you won't know until you ask, right? So I think asking and being prepared for potentially difficult answers is important. And, you know, maybe having a conversation off to the side, just saying, you know, right now, legally, your mom is able to make her own decisions. So I'm going to direct questions to her first. However, let's chat about what you think or how you think we should approach this, because this is the kind of information I need, and we should know it before there's a crisis situation. That might work. You might get shut down again and you end up having to do things on the fly every time there's an exacerbation or a crisis situation. And sometimes that just is the way it is.
Thank you.
You're welcome.
Okay, well, thank you so much, everyone, for coming. For those of you who are still here, we will be sending out an email, follow-up email with some lovely links and resources. So keep an eye out for that. If you don't see it, check your junk mail. Our emails tend to like to go there. Not quite sure, because Echo is super exciting. So is the network. So it should be top priority in everyone's inbox. Just kidding. But I hope everyone has a great day. And thank you, ladies, for the fantastic session. It was lovely.
Thank you, Amanda. Thanks, Linda.
Thanks.